going to talk about the Minocycline trial which we're running in Brisbane, and it certainly has several comparable features with the trial that you've just heard about. We started running this in October, or started recruiting patients for this in October last year, and we're running it in collaboration with the Rick Hansen Institute, which is a not-for-profit organisation in Canada looking after spinal cord patients. Now, I know most of this will be obvious, but there are still specific therapies are still lacking to improve neurological outcome after spinal cord injury, and patients still typically experience prolonged hospitalisation in acute care and rehab. Spasticity and pain add to the neurological impairment in about 25% of patients, and there are a high number of readmissions due to complications such as pressure sores, urinary tract infections, and pneumonia. Minocycline is a broad-spectrum tetracycline antibiotic. It has normally used to treat acne. It crosses the blood-brain barrier and enters the cerebral spinal fluid. Numerous studies have investigated its neuroprotective properties in all of these following conditions, including obviously spinal cord injury, Alzheimer's, multiple sclerosis, motor neurone disease, AIDS dementia, stroke, Huntington's disease, Parkinson's, and schizophrenia. They have had varied results of different studies across that broad range of conditions. The trial is funded by the Queensland Government in Brisbane. There was a grant called the NIRAP grant that was awarded to QUT, which is Queensland University of Technology, to fund spinal cord injury research projects in collaboration with the Rick Hansen Institute in Vancouver. There was a phase 2 trial, Minocycline trial, in 2008, which was run in Canada, where they recruited 54 patients for a Minocycline trial. And on the basis of that, the phase 3 trial is being run in 6 Canadian hospitals. And to date, we are the only overseas centre, although the Rick Hansen Institute have been working extremely hard to try and increase the number of centres taking part, including some in Europe, going to I think Saudi Arabia and China, but none of them have come off yet, mainly due to funding. The chief investigator of the whole trial is Dr. Steve Kasher, who's in Calgary. Professor Michael Schutz is the principal investigator in Brisbane, and there are 4 associate investigators. Similarly to the last trial, you've heard about the lengthy process in order to get a trial up and running and off the ground, even though we already had funding for it, was really quite complex and took about 18 months. So initially we got ethics approval from QUT, who held the funds. We had to get the hospital ethics approval, because obviously that's where the patients are. We had to get legal and financial agreements and contracts drawn up between all partners involved. So that was QUT, Princess Alexandra Hospital, and the Rick Hansen Institute. We had to get permission to import IV minocycline to Australia, because it is available in oral form here. It is not used in IV form. So in addition to asking to use it for a different purpose, we're actually using it in a different form. And we had to have a site initiation visit from the coordinating team in Canada. So the IV minocycline is actually manufactured in Japan, and then it would be sent to Canada, where it would be blind packaged for us, and then it was sent over here. And that process took a long time, but it did eventually happen. So it's a phase 3 clinical trial. It's multi-centred. Patients are randomised onto the treatment arm or to the placebo arm. It's double-blinded, so that again, patients and the treating team are not aware, should not be aware of whether their patient is receiving the drug or the placebo. And it is designed at the Rick Hansen Institute. And the aim of it is to assess the efficacy of IV minocycline in improving neurological and functional outcome after an acute traumatic non-penetrating spinal cord injury. So the intervention is that IV minocycline is infused every 12 hours for a week after injury. The control is a placebo, which is just normal saline. There are various outcomes, which I will talk a little bit more about later, but primarily our primary responsibility is the safety of the patient, to make sure that they haven't got any adverse events that may be linked to being on the trial. The regular ASIA scores. The SF36 is a quality of life questionnaire, which is done at set intervals. And the SCIM is the independence questionnaire, which assesses how much patients can or cannot do for themselves. Patients are followed up on this trial for 1 year. So the first official outcome measure is at 3 weeks, then 6 weeks, 3 months, 6 months, and then 12 months. Worldwide, we would like to recruit 240 patients onto this trial over a 4-year period. And we estimated that we should be able to recruit 5 patients a year from Queensland, and that is exactly what we've done in the last 13 months. And the reason that it's only 5 is because of the inclusion-exclusion criteria, which I'll talk to you a little bit more about. So the inclusion criteria is the patients need to be at least 16 years old, and they need to be able to provide informed consent. So therefore, they need to be conscious and awake to do that. They need to have an acute non-penetrating cervical spinal cord injury, and they need to have a detectable change on an ASIA motor assessment. The most important thing is they must be randomized and receive the first dose of the trial drug within 12 hours of injury, and that is our biggest challenge given the geography of these enormous states that we live in. There is many exclusion criteria. I won't go through every one, but the main one that we have is the fact that they have had the injury more than 12 hours ago, and also other associated trauma which might interfere with consent. So if they have had a head injury and they're not really able to comply with an ASIA examination or understand what they're consenting to, we need to exclude them. And also if they have a major limb fracture, then that can interfere with the ASIA assessment, and if we cannot get a baseline ASIA assessment, we don't have anything to compare later assessments and outcomes to. There are other some blood parameters, blood chemistry that we need to go through as well, and they cannot be pregnant. So we do look at their past medical history at the time of admission. So on the trial so far, worldwide, we've only recruited 21 patients. And similarly to the other trial, we've been extremely quiet over the last few months. And interestingly, so have Canada. Even though that you would think, having been there summer, they would have had a very busy period, but they have had, I think, 2 patients recruited in the last 5 months from all 6 of their centres. So we recruited 5 patients from Princess Alexandra Hospital since October last year. So 2 of those patients dived into shallow pools. It was a female aged 33 and a male aged 19. 1 patient had a dirt bike accident. It was a male aged 29. 1 patient was assaulted in a pub. He was 42. 1 patient had rugby injury. He was 41. And all 5 patients have had their accidents during a weekend, and 3 of them at night time. And 3 of these patients were under the influence of alcohol at the time of their injury. The patient journey, the consent process, we are usually consenting patients in the resus rooms of the emergency department. Obviously, there's an awful lot else going on for them at that point, and it's a very stressful environment. Often there is next of kin there, a parent or a partner, and we involve them in the consent process, but we do need to have consent from the patient, although the partner or next of kin can actually sign, obviously, because the patients usually are not able to physically sign the consent form. In the early days, we visit the patients daily to make sure that they still understand the trial. A lot of patients lose the concept that they may not actually be receiving the drug. They may be receiving the placebo, and that's really important for us to make sure that they do understand that. And they can withdraw at any time. We haven't had any patients refuse to go on the trial, and we haven't had anybody withdraw. To date, 2 of these patients still remain on the spinal injury unit at Princess Alexandra Hospital, so that's 11 months and 6 months since their injuries. And 3 patients have been discharged after 4 months, 10 months and 8 months on the unit. So the main recruitment blocks we've had is arriving to Princess Alexandra Hospital with over 12 hours after the injury. And often we can be 13, 14, 15 hours. It's not always that far out, but it is out of that window. And the other thing we have is the patient level of consciousness. Obviously, if they've got a high C-spine injury, they've usually been intubated. Presence of other traumatic injuries, we've had to exclude people because of that. And the level of spinal cord injury, sometimes we've had calls about people, but it actually turns out they've got a thoracic injury. And also, in one case, we had a patient with elevated liver function tests on admission. So the study procedure, once the patient is on the trial, they are assigned to either the control group or the treatment group. That is a randomized process. They all have an insertion of a central line, and for that reason we also tend not to take Asia D patients, because they have, clinically they don't really need to have a central line, and we need to be able to be going with the treatment they would be having anyway. They're not really severe enough to be warranting a central line. So the placebo group have normal saline infused every 12 hours for a week, over 30 minutes, and the treatment group have minocycline, which is diluted in normal saline, infused in over the same time period. The bag and the line is all covered up. Minocycline is light sensitive, but also minocycline turns yellow when it's reconstituted, and obviously normal saline doesn't. And so although we don't have so many numbers that we have patients next to each other noticing that something would be different, it just prevents people seeing that, you know, and asking any questions about what's in there. One of the major challenges we've had is the drug packaging is actually not properly blinded. So when the kit comes out, that is blinded. When we open up the kit, when you open up each dose of drug, the placebo is actually an empty vial, so there is actually nothing to reconstitute, and that is a major challenge we've had in keeping the study team and the patient blinded. And over 14 doses, that can potentially be 14 different members of staff on a ward, all knowing whether this patient is on the trial or not, or on the drug, or is not receiving the drug, and the potential for that information being disclosed is quite significant. So for that reason, we appointed a specific trial nurse who comes in and in a very dedicated way, comes in every 12 hours for that week. She stores the drug and she dispenses the drug and she covers it up so nobody else can find out so she is the only one that finds out whether that patient is on the drug or not on the drug. But she doesn't do any of the outcome measures, so that is, we got approval from Canada for that to happen. And one of the other issues we had to go back to Canada and ask whether we could change it so it was, you know, more effectively blinded, if some sort of yellow colouring could be put in the normal saline. But because the phase 2 trial in 2008 was done in this way, the phase 3 trial has to exactly replicate what the phase 2 trial was. So in order for the study procedures, if the patient is going to have spinal cord decompression, this must be performed within 12 hours of injury. And in fact, all of those patients have had it within about 8 to 9 hours of injury. Their mean arterial pressure, which is essentially their blood pressure, needs to be maintained at least 65 to maintain oxygen perfusion to the vital organs. There are ongoing studies about the benefit of increasing this in spinal cord injuries to 85, but that is not clinically proven yet. Minocycline can be liver toxic, and so we have daily liver function tests for the week that the patient is on the drug. We have found that LFTs do go up, but when we looked at another group of patients with similar injuries, we went back and looked at their charts, we found that liver function tests seem to often increase after a spinal cord injury, so we cannot necessarily assign it to whether they may or may not be receiving the minocycline. So the outcome measures for exactly the same for both groups. Obviously the safety, monitoring the incidence and severity of any adverse events. The ASIA score is done at 1 day, 3 days, 7 days, and then at the other intervals that I mentioned earlier. The ASIA is done by study physios who we have recruited specifically for the trial, and we pay them to come and do these ASIA assessments on these patients. As mentioned previously, they are quite lengthy, but it also means that all of these study physios have been signed off on the same course by the Rick Hansen Institute to make absolutely sure that everybody who's doing these ASIA scores is working to the same guidelines. The quality of life assessment and the independence measure questionnaires are done from 3 weeks up to 12 months. And I think the idea is that using a variety of outcome tools will provide us a comprehensive picture of patients' function level and ability. Our reporting requirements, we need to report all serious adverse events to QT and PA, ethics boards, and to the Rick Hansen Institute. We collect all the data on adverse events and any associated medication which is given. So, for example, if a patient develops pneumonia, we collect all the data around any drug, any antibiotic they're prescribed to treat that, and how long they're given that for. Safety reports are gathered from all the data by the Rick Hansen Institute every 6 months and are distributed to all the centres, and these are reported to the ethics boards. And all the patient data is uploaded and stored on a secure web-based database. So raised LFTs have been observed in most of our patients and do seem to often be observed after a spinal cord injury. And in 2 cases we have ceased or interrupted the minocycline or placebo as a precaution. The adverse events that we have observed are obviously very common in patients after a spinal cord injury. So they include urinary tract infections, lung collapse, autonomic dysreflexia, pressure sores, and all raised LFTs have been resolved within 6 weeks of injury. In terms of serious adverse events, 1 patient had a pulmonary embolism. We did have a sad situation in that 1 patient who was in for 4 months actually died 5 months later in a road traffic accident, and even though it wasn't connected to the trial, because he was still on the trial, it was still within those 12 months of him being on the trial. That is all reportable to the ethics boards, and we obviously report those to all 3 of those organisations. Patients are often very interested to know whether they're on the drug or on the placebo, and also interested to know whether which other patients are on the trial. And because they're all on the same spinal injury unit for months on end, they do find that information out and swap notes. And they have asked us whether they can find out which arm of the trial they're on, and the answer to that is yes, probably in 2019 when the trial's finished. So in terms of trying to increase our recruitment rates, we've communicated with the Queensland Ambulance Service, with the Air Retrieval and Disaster Management Service, and all the likely referral hospitals around Queensland, which was about 20 hospitals, to try and decrease the amount of time it takes for the patients to get from the scene of the accident to the Princess Alexandra Hospital. Rick Hansen Institute are also reviewing the inclusion and exclusion criteria to try and see whether there's any possibility of stretching the window out to maybe even 14 hours, or maybe taking patients who have got some other injuries, or whether that really is going to end up with data that actually doesn't mean anything. So for the future, obviously neuroprotection remains a critical first principle of management. And it's unlikely that any one treatment will reverse a spinal cord injury, and we are very honest with patients at the time when we're recruiting them, and as things have gone, but we're not seeing this as a miracle cure. We hope that our contribution to the trial could have a direct impact on a first-line treatment for patients in the future. And we hope that, having run this, that future trials may be a possibility, as there are several projects in the wings, and the more used as a hospital we can get to having patients on clinical trials, the better recruitment centre we will hopefully be.